بسم الله الرحمن الرحيم. ارجو ان انتم ما تكونوش هايبوجلايسيميك او ساتوريتد يعني، وبشكر طبعا الباناليست وشكر خاص للاستاذ الدكتور محمد بيه صبحي for this invitation. So my presentation today is about heart failure with preserved ejection fraction and the message from recent trials. Key pointer. Okay, so treat often, cure sometimes, comfort always, and harm nothing, and this is according to Hippocrates. وده مهم جدا ان احنا at least لو مش هنفيد العيان ما نضروش، فدي نقطة مهمة جدا في البراكتس اوف ميديسن مش في الكارديولوجي بس. So heart failure with preserved ejection fraction, we have some challenges and unmet needs. Heart failure with preserved ejection fraction is one of the commonest forms of heart failure. It constitutes about more than 80% of elderly women with heart failure. It's almost as equal to heart failure with reduced ejection fraction in complications, morbidity, and mortality. Unfortunately, trials of heart failure with preserved ejection fraction fail to show a reduction in morbidity or mortality. Our understanding of heart failure with preserved ejection fraction, HFpEF, pathophysiology is actually incomplete. There are many knowledge gaps in this. Unlike the heart failure with reduced ejection fraction, which is to some extent well understood, there are many comorbidities زي ما زملائي واساتذتي الافاضل اشاروا: hypertension, atrial fibrillation, diabetes mellitus, obesity, obstructive sleep apnea. The key point of heart failure with preserved ejection fraction is heterogeneity. Heterogeneous everything, heterogeneous pathophysiology, predisposing factors, associated comorbidities, clinical presentation, response to therapy, morbidity, and prognosis. And this is actually why most of trials fail to meet their endpoints in patients with heart failure and preserved ejection fraction. There are clusters of heterogeneity. As you see here, we have heterogeneous risk factors, heterogeneous pathology, different LV structural remodeling, reduction of all functional reserve in heart failure, abnormal hemodynamics, secondary organ dysfunction, which end to heart failure with preserved ejection fraction. There are many other aging, sedentary lifestyle, obesity, ventricular stiffness, hypertensive remodeling, which lead to the syndrome of heart failure with preserved ejection fraction. Even in presentation itself, it's heterogeneous. So heart failure with preserved ejection fraction, clinical presentation is different, and actually predisposing factor different. Plus coronary artery disease, different from renal dysfunction, hypertension, metabolic syndrome. So it's heterogeneous everywhere. So the therapeutic targets could be RAS inhibition, neprilysin inhibition, volume deloading, heart rate reduction, risk factors and comorbidities management, exercise training, and pressure unloading. There are many actually of therapeutic targets in heart failure with preserved ejection fraction. There are so many trials in heart failure with preserved ejection fraction, and I have selected some of them. One of them, like initially in early 2010, RAS inhibition was shown preserved, and this tested actually the effect of candesartan in patients with heart failure as ARP, and this composite cardiovascular death of hospitalization, candesartan versus placebo, was actually not so different. So it didn't meet the endpoint in morbidity. However, there were some improvement in heart failure hospitalization, and this led to 2B class of recommendation for prescribing ARPs in patients with heart failure with preserved ejection fraction. When they try to repeat this with irbesartan, it fails in meeting any of their endpoints, morbidity or mortality, or hospitalization or mortality. And when they did it with brentopril, again, which is one of the important ACE inhibitors, again, it didn't meet the endpoint criteria. So RAS inhibition per se is not one of the successful medications for heart failure with preserved ejection fraction. The second logic management of heart failure with preserved ejection fraction is reduction of heart rate, which will lead to prolongation of diastole, and this will make much better filling. However, reduction of heart rate in many registries like optimized heart failure registry and other beta blockers, again, didn't exert special effect on mortality of patients with HFpEF. What about mineralocorticoid suppression like the spironolactone? And this is TopCat trial, a bit controversial trial done in USA and parts of Russia. And again, there was no reduction in primary endpoint, which is mortality due to heart failure. Reduction in secondary endpoint was observed, and there was some controversies between the arm of USA and the arm of Russia in this study. So again, this put into class 2B recommendation for management of heart failure with preserved ejection fraction. So what about neprilysin inhibition like Paragon heart failure trial? And I was one of thinkers that it might change the paradigm of heart failure with preserved ejection fraction. However, after this very sophisticated trial, it didn't affect mortality. However, it improved a little bit the secondary endpoint, but not to the level of significance between both groups. And you can see that the secondary outcomes, NIHA class improvement in sacubitril valsartan versus the valsartan group with significant, this is considered as secondary endpoint, not the primary one, which was not significant. So again, it was disappointing trial if we can tell. We have what's called vericiguat, and this is actually an oral soluble guanylate cyclase stimulator, which thought to improve patients with heart failure with preserved ejection fraction by increasing the energetics of cardiac myocytes. However, it didn't improve the mortality, but there were some improvement in quality of life. So we can abbreviate the sum of data of medications in symptoms, hospitalization, mortality. Diuretics improve congestion. Beta blockers, mineralocorticoid receptor antagonists, no evidence on symptom relief. AC, ARBs, inconsistent evidence. Some candesartan, the first one, improved NIHA class. Hospitalization, nidivilol, digoxin, spironolactone, candesartan may reduce heart failure hospitalization. Mortality, actually, there is no significant reduction of mortality except with nibivilol in older patients, which reduced combined endpoints of mortality and hospitalization. Actually, the most successful studies or trials in heart failure with preserved ejection fraction was what's related to exercise training, improvement of quality of life by make some sort of exercise training for patients with heart failure. Those were very effective. However, the endpoints of those trials were subjective endpoints, improvement in quality of life rather than hospitalization or mortality. This is one of the interventional studies in patients with heart failure with preserved ejection fraction, which is unloading the left atrial pressure by doing interatrial shunt. This is reduce left atrial pressure heart failure trial, and it was done as initial safe procedure. Now there is an ongoing trial which is reduce lab heart failure 1, and the results are awaiting. There are many other trials in the pipeline. One of them is the liver trial, dapagliflozin. The other one is empagliflozin. Both of them SGLT2 inhibitors, which have some sort of diuretic effect and possible plausible effect in improving quality of life in patients with heart failure with reduced ejection fraction. And there is Vitality heart failure with preserved ejection fraction trial, still another ongoing one with very SIGWAT. So my take-home message, Mr. Chairman, that messages from recent trials in heart failure with preserved ejection fraction, no definitive therapy. Sorry, can I have just 2 minutes? Thank you. Thank you. So number one, no definitive therapy for heart failure with preserved ejection fraction. We have to address and manage comorbidities. We have to tailor therapy according to phenotypes, to different types of heart failure with preserved ejection fraction. AF, coronary artery disease, renal impairment, obesity, diabetes, and so on. And we have to fill the knowledge gaps, and there are many knowledge gaps in the pathophysiology and management of heart failure with preserved ejection fraction. And the last important message, that we need more trials, we need more innovations, and we need more time. If you need the sophisticated abbreviation of how to manage heart failure with preserved ejection fraction, is one, don't miss the diagnosis. You have to put it in your mind. Before treating HFpEF, remember to evaluate for the causes, rare causes like amyloidosis, for example. Categorize patients according to the phenotype. General treatment recommendation, treat of blood pressure, fluid overload, atrial fibrillation, diabetes. Treat comorbidities, tailor treatment according to phenotypes, and then enroll in heart failure. And these are the important different categories of treating patients with heart failure with preserved ejection fraction. Thank you very much.